thing for them. And somatometin C is by far the most common one, and it basically will bind to a growth hormone dependent carrier protein, and that promotes its half-life so that it can get to tissue sites and do what it's supposed to do. As I said, it's the most important. Its effect on fat is identical to insulin. What's insulin do to fat?
Break it down.
Break it down, because you got to have the fat basically to make glucose and stuff to make the body, right? It also promotes protein synthesis at all levels, and so DNA, RNA, and also their transport and all those type of things. So you can see it's one of the components is mainly under the control of somatometin, this type of thing. Okay. Now, there are two receptors specifically for it. The IGF-1R, it binds the IGF-1 preferentially. It also binds a few of the other ones. There's about 20 of these things. But the only ones you really need to know much about are one. And you have the IGF-RH, which binds the IGF-11 preferentially, and also IGF-1. So what are the two, or IGF-2 rather, no, 11 is 2. So what are the two most important IGFs, you think? 1 and 2. Yes, sir.
Okay, so insulin breaks down fat. But I thought...
Well, insulin causes glucose to go into tissues, right?
Right.
So what will happen to blood glucose levels?
It'll go down.
It'll go down. So what will the body be stimulated to do?
Great oxidation.
Yeah, make more glucose. Okay? So it's a cycle, right? And unfortunately, if we would leave that cycle alone, it would probably be all right. But when we try to change that cycle with diets and that dangerous thing called exercise and all that kind of stuff, we affect those regulations, right? Okay, a third receptor is the insulin receptor. It has similar functions to that of your specific somatometin receptors, and that it will bind insulin preferentially, but it can also bind the IGF-1. Not as potent as insulin, but it can bind those. And basically, this probably accounts for why they can call it insulin-like growth factors. Because if it can bind to insulin receptors, it can elicit the same response that insulin does. So if we look at the direct and indirect effects of growth hormone, you can see what's it doing to fat? It's breaking it down. And it's a direct effect of the hormone on that organ, right? Now what do you think an indirect effect would be? That means it's mediated through another organ. So it binds to the receptors in the liver, and then causes the liver to produce those insulin-like growth factors, and then they will have their effect. So what's happening, what's insulin-like growth factor doing to the bone there? Making it grow. Now, did the growth hormone do that directly, or did it do that using an intermediate? So that's why they call it indirect effect. Okay. Which one do you think is going to be faster, direct or indirect?
Direct.
It's direct. Now, it has major effects on metabolism. They're both anabolic and catabolic in nature. Your protein metabolism, you're going to stimulate amino acid transport, ribosomal activity, messenger RNA synthesis, etc. And what all is that going to do? You do all that, what are you going to make? You'll make proteins, right?
Sure.
So is that anabolic or is that catabolic?
Anabolic.
That's anabolic. So it promotes a positive nitrogen and phosphorus balance as far as the body is concerned. Now look at lipid metabolism. What's it doing to lipids?
Breaking it down.
Breaking it down. Because in beta oxidation resulting in enhanced utilization of fat by tissue. So is that anabolic or catabolic?
Catabolic.
That's catabolic. Now that catabolic effect gives you the stuff that then you can have anabolic effects. But its effect of the growth hormone is catabolic. Okay? And you can see all this is all in balance. You know, if you've got everything you need, do you need the catabolic effects or do you have major anabolic effects? The antibiotic. When that gets to the point where you don't need that anymore, or if you don't have the nutrients required to do that, what are you going to have to do? The catabolic effects. So what's the overall purpose of this hormone? Keep things in balance. Okay, and also to allow for growth and stuff, right? Now, as far as carbohydrate metabolism, it decreases your cellular uptake by suppressing the ability of insulin to stimulate uptake of glucose by peripheral tissues. So what's it trying to do to glucose? It's trying to basically increase blood glucose, isn't it? So it's going to do that by two ways. It'll help keep the tissues at first from taking it up, and then it's going to stimulate the liver to make glucose. So you're putting those together. So basically you're going to get hepatic glucose production stimulated. You're going to get decreased tissue binding of insulin. You're going to decrease insulin receptors in the cell membrane. You're going to inhibit insulin action by modifying the intracellular processes by, due to via increased calcium-dependent ATPase, etc., like that. So in other words, what's it trying to do? What's it trying to do to blood glucose? Trying to raise it, okay? So that when you get to a certain level, then this growth hormone drops, and what's going to happen? What happens to the insulin receptors then? They're activated. Where's the glucose going to go? Then into the tissues. Okay, so in other words, what it's doing is it's building up the glucose so that then the tissues can get a good burst of it to be able to respond and do what they're supposed to do. So if we look at that, in other words, growth hormone causes increased blood glucose, right? Because it inhibits insulin receptors, right? Now, as that glucose elevates to a certain level, when it gets to a certain level, it shuts off the growth hormone. What's going to happen to the insulin receptors? They're activated. What will happen to blood glucose? Move down. So that's the regulatory mechanism for growth hormone. Now, as long as those blood glucose levels are low, are you going to shut off that growth hormone? No. And what's that growth hormone going to try to do to blood glucose levels?
Increase.
Increase them. So that's the mechanism you have. Everybody follow that? So it's basically your blood glucose. So what do you think would be a test you could find out but whether or not the cells up there are responding to negative feedback and stuff? How about giving glucose and measuring your growth hormone levels and stuff? If this thing doesn't care less about negative feedback, are you going to diminish the growth hormone levels by giving glucose? No. So that tells you we have over-secretion. In the normal animal, if I give them glucose, what should happen to my growth hormone level? It should drop. If it doesn't, something's wrong up here. Do I follow that? And that's one of the things we're looking at with that. Okay? So you can say, well, I'm going to be growth hormone if it prevents tissues from taking it up. Why it is that it is making sure that there's build up enough glucose so that then the tissues can get it and get you a good burst of activity. That's what they're saying. Okay, in other words, if you just have low glucose levels, are any of the tissues going to be well off? No, so you build up that glucose level and then you'll put it into those tissues which really need growth, like muscle and all that type of thing. So it will get the glucose. Okay, this is just showing you the metabolic effects of the growth hormone on adipose tissue, skeletal muscle, and liver. You can see what it does to those and what the result is when it does that. And if you look at that, as far as the on adipose tissue, it's going to increase free fatty acids in circulation. And what can the body use those free fatty acids to make? Glucose. Okay? On skeletal muscle, it's going to decrease glucose uptake, so it's anti-insulin, and it's going to increase amino acid uptake. So if the muscle's taking up more amino acids, what's happening to it?
They're
It's building up, right?
building protein.
Okay. If you look at the liver, it increases ketogenesis. Basically, you've got those ketone bodies, and what do we use ketone? Can we use ketone bodies for energy and for ATP and all that?
Yes.
Yes. Okay, and so it also increases glycogenolysis and gluconeogenesis to do what? Build up blood glucose. Okay. Now, so the effects of growth hormone are mainly on, as we say, anabolic in nature. The major role of growth hormone is to stimulate body growth, and it's to stimulate the liver and other tissues to secrete those insulin-like growth factors so that you can get the glucose going into these tissues to give you growth. Okay. Now, through both its direct and indirect effects, it's going to stimulate the growth and development of just about every organ system, but it's mainly your muscle, or skeletal muscle, also cardiac muscle for that effect, connective tissue, soft tissue, bone, epiphyseal cartilage, and all that stuff, because what has to continually grow as you're developing? Those areas. So that's what it's used for. This is just showing you the indirect anabolic action and direct catabolic action that we have with that. So this flow chart just summarizes those effects we talked about. So you can see how growth hormone is pretty important, isn't it? So do you think you're going to get just mild problems when you don't have enough growth hormone? Or are you going to get some severe problems?
Severe.
Severe. What if you have too much growth hormone? Is that going to cause some problems too?
Mm-hmm.
Is it going to affect one organ, or is it going to be a lot of different systems involved? A lot of different systems involved. Again, this is just a summary of your effects of growth hormone on the different tissues and on metabolism. You need to keep these in mind, because if, that's the way you can interpret what's going on with our cases if you know these. Now, what regulates it? It's modulated by the hypothalamus and also by feedback mechanisms. In other words, if you got increased growth hormone, what's that going to do to the release of the releasing hormone by the hypothalamus? It's going to shut it down. So it's a negative feedback mechanism that we see there. Also, your somatostatin from the hypothalamus is going to inhibit growth hormone secretion and synthesis. And also your growth hormone secretion is again negative feedback with both growth hormone and with those insulin-like growth factors. In other words, it stimulates the increase of those in the blood. They go back and shut off negative feedback as far as growth hormone is secreted. So there's more than one mechanism to control it. And again, does that also stress the importance of this hormone? And how if it goes haywire, you can have all kinds of problems. So it has to be controlled. And also glucose. That's a negative feedback when it reaches a certain level. And then once it reaches a certain level, that negative feedback stops and the growth hormone is released. And this is just showing you also little things like stress, sleep rhythms can do it, all this type of thing. Because when do you think you're probably going to do your most growth? When you're out there running around or when you're sleeping? Usually sleeping. It depends a little bit on the individual, that type of thing. Okay, as you can see, there's a lot more complicated regulatory factors involved because of basically the magnitude of its effects. Yeah, so basically other factors, as we said, stress, exercise, nutrition, sleep, stimulate growth hormone release. Hypoglycemia is going to stimulate growth hormone release because, again, it's going to inhibit insulin receptors, so what will happen to blood glucose? It'll build up. When it reaches a certain level, then it'll shut off that growth hormone release. High protein will increase growth hormone, and paradoxically, very low concentrations of protein will also increase it. Remember, it stimulates protein buildup, right? But it can also stimulate breakdown of amino acids. So the low amino acids are going to tell, hey, we need more growth hormone in here to stimulate the insulin and everything to produce gluconeogenesis and stuff like that. Okay. Fatty acids suppress growth hormone response to basically some of your amino acids that are necessary to make proteins and stuff. Also hypoglycemia and that type of thing. So again, there's a lot of things. What do you think hypothyroidism is going to be due to growth hormone? What's hypothyroidism going to do with metabolism? Slow it down. What's that going to do to the need to grow and all that kind of stuff? Decrease it. So hypothyroidism can inhibit growth hormone production. Okay. So here you can see factors that increase it, factors that decrease it. These are just a few of them. There's a lot more, but these are the main ones right here. Okay. And let's look at disorders. What's hyposomatotropism? What do you think that means?
Low somatotropin release.
Low secretion of growth hormone. It can be, remember we talked about the pituitary can be congenital and all this. This can be congenital, and that's called pituitary dwarfism. Yes, ma'am.
Kind of going back to the last slide, how does hypo and hyperthyroidism both decrease the effects of?
Well, hypo, as far as hypothyroidism, is going to decrease it because you don't have the metabolism. Now, if you have hyperthyroidism, then do you want to just keep building and building and building, or do you want to regulate the size? What's the effect hypothyroidism have on the heart? It causes hypertrophy. Do you want to try to see if you can decrease that a little bit? So your growth hormone will decrease to try to take that stimulus away. In other words, it's a compensatory mechanism. Okay? That makes sense?
Yeah.
Okay. All right, so congenital is called pituitary dwarfism, whereas you can also get acquired hyposomatotrophism. Now, hypersomatotropism is when you have too much growth hormone. If it occurs before you have epiphyseal bone closure, the bones can still grow in length, right? So you get gigantism. If it's after you have epiphyseal bone closure, can they grow in length?
No.
No, they broaden, and that's called acromegaly. All right. There's an example of hyposomatotrophism in some dogs. These two are litter mates right here. Which one do you think's affected?
The small one?
Oh, that has gigantism, right?
No.
No,
that's
that
not
has pituitary dwarfism. What about this little guy right here?
one.
That's pituitary dwarf. Oh, he's so cute. Let's go breed him and get some more of him, right? And what do you think's going to happen to this problem? Going to be increased.
He looks sad.
This is actually a year-old dog. It's like a puppy, doesn't it? But you notice the proportions stay equal, okay? And that's one of the things you'll see with pituitary dwarfism is that the proportions of the body stay in correct order and stuff, but they're just not big, they're not growing like they are, okay? So as far as congenital hyposomatotropism, the etiology, it's usually due to a malformation or dysfunction in the adeноhypophysis. Do you think it's probably just going to involve the somatotropes, or you're probably going to see some other problems with the rest of the pituitary? It's usually going to be more of a pan-pituitarism type problem. It's mostly associated with basically cystic distension of the craniopharyngeal duct. You remember that's Rathke's pouch? You remember that from neuro? And the problem is that thing keeps dilating. What's it going to do to the cells around it?
Push
Get atrophy, pressure atrophy and stuff. These cysts are actually more common in dogs and animals than pituitary dwarfism is rare, because lots of times they don't give you any abnormalities, but they can. Incidence is relatively rare, but has been documented in both dogs and cats. There's probably been some incidence in large animals, but unfortunately, if a large animal, if a calf is born funny, what usually happens to the
Called.
Yeah, so those types of things. It does occur sporadically in your other domestic species. These are some potential causes of small stature in dogs and cats, so don't say, oh, he's small, he's got pituitary dwarfism. There's a bunch of other things which can affect how big or little that the animal is. There's endocrine and non-endocrine things. So in other words, don't just jump the gun, okay? So that's what we got here, okay? Got to prove it. Signalment. Affected animals usually appear normal until about 3 to 4 months of age, and then they just don't grow. And they keep their puppy-like or kitten-like things, okay? No apparent sex predilection, but it does seem to occur more often in Weimaraners and German Shepherds, with a lesser incidence in Spitz, toy pinchers, and the Cornelian bear dog. But again, if I've told you before, if you ask what's the most common breed associated with endocrinopathy, usually it's going to be German Shepherds or Great Danes or Poodles. So they have a lot of it in there. The clinical signs are variable, but basically lack of growth, short stature. You can get dermatological problems because you don't have very good development of the protective mechanisms of the skin, such as the glands and this type of thing. So you see problems with that. They will get progressively listless, dull, and inactive as they get older. And basically, it's not a nice thing. This is a Cornelian bear dog, in case you don't know. They raise them to chase polar bears. So I tell you, they do have, the brain's not developed. Is anything going to go after a polar bear? It's crazy. Okay. Now, as far as affected animals, are usually normal in size, as we say, during the first 1 to 3 months, but then they just stop growing. And they keep looking like a puppy, okay, or a kitten. But the contour and the proportions are normal. They equally do not grow, in other words, okay? They will retain your puppy hair coat, and unfortunately, is that a very resistant hair coat to rubbing and stuff? And so you will see alopecia associated with it, particularly if they have a collar on. You can see it underneath the collar. You'll see it on the proximal limbs. The skin, as you lose the hair, what's going to happen to the protection against UV light? So you're going to get darkened, acanthosis nigrans darkened, and also the skin does not develop very well. You're going to get very thin, wrinkled, and scaly skin as they get older. Okay. And what's going to happen to the protection mechanism that the skin usually gives an animal? It's not going to be there, so you're going to get a lot of bacterial infections of the skin, also the respiratory tract, and you can get long-term complications with infectious agents from that. Signs of secondary hypothyroidism and secondary hyperthyroidism may also develop. In other words, what caused it not to develop may affect the rest of the brain up there. There's just the clinical signs that are associated with pituitary dwarfism about as far as the different systems. And when you're talking about the musculoskeletal, reproductive, dermatological, and then other signs, you're hitting just about all the body systems in there. And you can see what you're going to get as far as that's concerned. Okay, the one on the left is a 1.5-year-old female German Shepherd. At pituitary dwarfism, the dog size was similar to that of a 4-month-old German Shepherd puppy. Now, look on the one on the right, that's an 11-month-old female golden retriever, and the dog size was similar to that of a 10-week-old puppy. But you can see the proportions aren't that bad, are they? They just look like tiny little puppies, don't they? Now, for both of those dogs, you had normal body contour, as we say, but the hair coat's not very, it's a juvenile hair coat and all this type of thing. Now, as they get older, then you're going to get all the complications from the secondary infections and everything else.
Would you have issues with either retained deciduous teeth or crowding?
You can, yeah. You have all those problems. All right, what do you think about that little puppy on the left there? 7-month-old. And he's German Shepherd and pituitary dwarfism. He weighed a whopping 4.7 kilograms.
Oh.
That's about right. Most people, when they get born, just about, isn't it? And you can see how tall that one is on the right there. That's a 5-month-old German Shepherd. That's a foot ruler there. You can see how big they are. Okay. And you can see what can progress. So cute. And then what's going to happen? See, look at the poor one. What do you think about that one in the bottom right there? Yeah, he's lost all his hair. He has acanthosis nigrans everywhere. And does he look like he's healthy, or is he about ready to drop?